I will try to face two challenges this afternoon. The first one is to talk just before the coffee break. And the second one is to talk about internal dosimetry. In fact, internal dosimetry is an incorrect word because every dose are internal, as you know. But when I'm talking about internal dosimetry here, I am referring to the dose which are delivered after intake of radionuclides, after either inhalation or ingestion of radionuclides. So you already know that the exposure to radioactivity is managed by the use of effective dose. In case of external exposure, we use the effective dose, but in case of internal exposure, internal contamination, we use this specific quantity, which is a committed effective dose, which take into account the integrated activity over time. And for the worker, you already know that we integrate the activity over 50 years and up to the age of 70 for the member of the public. The problem is that once you have said that, the problem is that to calculate or to measure the committed effective dose, we do not have any operational quantity to measure the committed effective dose, and the only way to do that is to calculate, to make calculations. So to do that, you first need to know the intake. I'm sure you know all this, but it is maybe worth mentioning it again. So you need to know the intake. And then after the intake, you need to know where the radioactivity, where the radionuclides goes in the body. You should know in which organs they go and how long they stay. So this is what we call deposition in tissue. You can do that either by going through the literature, or you can also go through the biokinetic model, which are set up by the ICRP. And this biokinetic model, you already know what they are now because we had very good presentation just before. This model are nothing else than a sum of boxes and arrow. And this box tells you exactly where the radioactivity goes. And this arrow tells you where it goes after initial deposition. And it also tells you at which rate it goes. So ICRP has developed many models. They have developed one model after ingestion. This is the human alimentary tract model. They have developed one model after intake by breathing. This is the human respiratory tract model. They have developed model after translocation of the radioactivity from the lung or from the GI tract to the systemic organ. This is called the systemic model. And we have also wound model, which were not developed by ICRP because exposure to the wound is not a current situation, but they have been developed in conjunction with the NCRP. So we have model for every route of entry. So once you've got you know where it goes, you should still know the number of transformation, number of disintegration in the tissue. Then you need to go the energy which is emitted, and to do that you need to know the nuclear data. Then you use phantom and code for radiation transport. We have talked on that before to calculate the absorbed dose in tissue. Then you use weighting factor for radiation to calculate the equivalent dose in tissue. And then at the end, you are lucky enough, you can calculate the effective dose by using the weighting factor for tissue. And all this is given by the dosimetric model, which were described before. So if I try to summarize, you need to know the intake, you use biokinetic model, dosimetric model, and go directly to the effective dose. This looks simple way to do that, but you can easily understand that every step, if you want to go through every step, it can be a very long procedure, very complex procedure, and I should say it is limited to very few experts around the world. So this is why ICRP has defined concepts and tools to allow almost everybody to perform those assessments. The first one is the dose per unit intake. The second one is the retention function. In fact, if you go back to this, my logigram, you still need to know the intake, but with the system proposed by the ICRP, you can ignore what is on the right of the slide. You can ignore the dosimetric model and biokinetic model just by using one coefficient, which is called the dose per unit intake. And that coefficient, of course, takes into account of everything which is in the biokinetic model and dosimetric model, and which is given like such as, small number here. And here you've got an example for uranium-234. Of course, we do have dose per unit intake for every radionuclides. And here in this example, you've got three numbers corresponding to different class of inhalation. different class of solubility. So to do that, it's really easy to use that. You just need to know the intake, and then the dose is just nothing else than the intake multiplied by this coefficient. It's really an easy way to calculate the dose. And this is how it is presented in the ICRP publication. Here is ICRP 68. You've got dose per unit intake for different AMAD, for different size of particle, and so on. The second tool which is proposed is when you have no idea of what the intake is. This could be the case in case of retrospective assessment of dose. When the guy comes to you, he has been contaminated, you have no idea of how much he has inhaled or ingested, and you need to guess the intakes. So the only way to do that here is to go directly from the bioassay. Bioassay, I mean the excreta, urine, feces. You can also make measurement of the lung, make measurement of whatever you want. And with this bioassay, you can go back to the intake, thanks to ICRP again. You can go back to the intake by using this retention function. And this retention function has the form of this curve. And these curves tell you at any time after contamination, tell you what should be the amount of radioactivity in one organ, in one bioassay, after a unit intake. For example, here I've taken the curve for the uranium-234 after inhalation of a compound which will not be soluble, which will be insoluble. And this curve shows you that if you measure something, let's say 3 years after contamination, it tells you that the intake should be 10 to 5 times the quantity you have measured in the bioassay. So at the end, once you have defined the intake through the retention function, you can use again the DPY to get the effective dose. So this is really easy to use, and because it is easy to use, the ICRP has produced many reports describing and giving this coefficient for almost every radionuclide. It has been done in the publication 30 series, which was dedicated to the exposure of worker. So it was a long series of documents given this coefficient for almost every radionuclides. It has been followed by a publication 68, which was an update according to the new recommendation, in 1999 recommendation. And also it has been accompanied by the publication 54 and 78, which were more guidance on the design on monitoring program. The ICRP have done exactly the same thing for the member of the public, especially after the Chernobyl accident, where it will become obvious that we also need this coefficient for children. And so we have got the publication 56 series, which gives exactly the same thing, the same coefficient for the member of the public. And then the publication 88 and 95 for the dose to the embryo, fetus, and dose to the infant. The problem, well, I should not say the problem. You have noticed that the first publication for the worker appeared 30 years ago, and during this 30 years ago, many progress has been done in science and in many fields. We had progress in physiology. We had progress in biokinetic model. First, we did have new data on the reference man. You know that the reference man is not a reference man anymore, but it's a reference man and a reference female. And we also have data for children at different age. You know that we did have a new alimentary tract model. Just to remind you, this was the former model, which was described in ICRP 30. It was a very easy model, just very easy to implement because it has only 4 compartments, but one should recognize that the physiology is maybe more complicated than that. And this is why we have developed, ICRP has developed a new human alimentary tract model, which take into account many things, which take into account the possible deposition on the teeth, the possible absorption through the oral mucosa. It also takes into account the possible deposition on the wall of different parts of the stomach, and it takes also into account a kind of recycling of radionuclides through the secretory organ and so on. So this model was definitely more physiologically realistic compared to the previous one. We also have new element-specific systemic model, which are again physiologically realistic. Again, I will not go back to every element, but just would like to give you a flavor with some example. Here is the model for iodine with the former model on your left, which was made of 3 compartments, and the new model here, which is made definitely of many additional compartments, which again represent probably more closely the reality. Another example for the strontium, another example for the radon, and the radon is a little bit new because it was not described in the previous publication. So we also have more realistic treatment of the biokinetic of radionuclide daughter. By the past, it was considered that the kinetics of the radionuclide, which will be born in the body, which will be the same as the kinetic of the parent, just because it was too much complicated to assess independent kinetics. And now we try to define independent kinetics for radionuclide daughter. We also have new data supporting the update of the human respiratory tract model. You know, this model was designed 21 years ago. So the idea was not to do a new model, but just to refine a little bit the parameter, to adjust the parameter according to the new data we got in science. And here, so there was many updates in this model. I would like just to focus on 2 dedicated on clearance. You know, after deposition of the radionuclide in the lung, you've got clearance, and the clearance is a kind of competitive process between absorption to the blood and transport of materials through the bronchial tree to go to be absorbed to the GI tract. And this is so we had update in the two parts, and here is this former particle transport model which was described in ICRP 66. And here is the new one. And in the new one, what we do recognize, we have changed a little bit here the deposition in the 2 compartments of the extrathoracic airway. So we consider here that only 65% deposit here. 1/3 is excluded to the environment by nose blowing. 2/3 are going to the posterior passage, to posterior part of this extrathoracic airway. We also have refined a little bit the transfer rate from this compartment to another, and we have also refined a little bit this compartment to better explain and to better represent the very long deposition of some radionuclides in the deep lung after inhalation. We also have made some other adjustment to this model on the absorption to the blood. You know, the absorption to the blood in the human respiratory tract model is given by type of absorption. We have defined the 3 types of absorption, which describe the absorption of the element to the blood. You can have a fast dissolution, medium dissolution, and very slow dissolution. So we do have a default parameter value for each one. But what we wanted also to do is to provide, as much as possible, to provide material-specific data or even element-specific data when they were available. And actually, in the science, we got many new data on uranium, and it was possible for us to define specific absorption parameter value for uranium, for type F, and the same for type M, and same for type S. And finally, on this human respiratory tract model, what we wanted to do also is to change a little bit the default parameter value. Here, you've got the parameter value for the previous respiratory tract model, and here for the new respiratory tract model. What does this data mean? Here, the data means that if you've got a type F, something which is very soluble, it tells you that 100 of the compound are solubilized with a rate of 100 per day. And here, we have changed a little bit the data just to take into account of the reality. And so we have here in the new model a greater rapid fraction, greater dissolution, and a slower dissolution rate here. We also have progress in dosimetry on monitoring with development of a computational phantom. We have talked about that before, so I won't come back to that. I just would like to highlight one small point, which is a new concept of the dose per content. In fact, you remember my diagram. I told you that if you want to calculate the dose, you can go through retention function and DPY. That's nice, but that's still source of mistake because it's made of two steps. So what we wanted to do is to reduce again the system to reduce the occasion of making mistake and to go directly from the bioassay to the effective dose by using only one coefficient, which is now the dose per content, and this dose per content will be proposed in the new version. We also had new ICRP recommendation with the adoption of the use of realistic phantom, change in weighting factor, change in calculation of equivalent dose. You remember that this was because we have a female phantom and male phantom, we propose now to average the equivalent dose before to go to the effective dose, and we also have been asked to provide those coefficients for the radon. So because of this, or thanks to this, because of all this improvement, it was time for us to review the past report and to provide new dose coefficient with also guidance on monitoring program and data interpretation. So what we have done, we have divided the work in two parts just because parts. So this is just to give you a flavor of what will be published. We decide to treat first the most important element for us, then to treat the lanthanide and protactinium, and then in part 5 to treat the other. So this is the date of publication of this data. Now, few minutes to talk about uncertainty and variability. I've been asked very often about the uncertainty when we calculate those coefficients. The problem of uncertainty and variability, first you have to define what is uncertainty and variability because there is many often confusion in the mind of people. Uncertainty for us is definitely due to the lack of knowledge of a central value for a population, which is different from the variability. Variability is just a result from difference between members, and that results from physiological and environmental factors. So, of course, variability may induce uncertainties, but this is not the, today I will talk only about uncertainty because you cannot do anything about variability. So uncertainty, when you want to calculate dose, you have uncertainty when you calculate dose, and this uncertainty depends, you have uncertainty at every step of the dose calculation. You have uncertainty when you measure the activity in the excreta or body. You have uncertainty in the exposure scenario, and this is particularly true when you are talking about retrospective assessment of dose. When you have, again, somebody who comes to you who has been contaminated, you may have absolutely no idea of the route of contamination, if it was by inhalation or by ingestion. You may have no idea of the time pattern of contamination. It can be chronic contamination, acute contamination. You have no idea of how long, when he has been contaminated. You have, in some cases, no idea of the radionuclides which are in cause, and you have sometimes, most of the time, no idea of the chemical form of the radionuclides. And you also have uncertainty in the models themselves, in the biokinetic and dosimetric model. So the problem with the biokinetic model is that you can have uncertainties both on the parameter value, this coefficient, which tell you how much goes from one compartment to another, and you can also have uncertainty on the structure itself of the model. So we all know that the models are wrong, but the problem is not is to know, I would say, how far they are wrong. And so the problem is that you know that for setting up model, you need data, and the data may be available or not available at all. When you set up model, you try to make the best use of human data when you have some. The best because we are setting up model for human, not for animals, so we need to use this human data. Fortunately enough, with this data available for most of the essential elements, like essential elements such as calcium or zinc or whatever, we also have very good set of human data for some radionuclides such as cesium, lead, radium, uranium, americium, plutonium, and so on. But in some cases also, you do not have this human data for this specific element, and you need to use what we call chemically similar elements, which are elements which have the same, almost the same chemical behavior. And this is the case, for example, for the lanthonide. For the lanthonide, we did have, when we tried to set up model, a good set of data for the cerium, but we did not have enough data for the other element. Who cares about the holmium, about the dysprosium? So this was our problem, and we were obliged to extrapolate the data based on the chemical analogy. The problem is that you can have chemical analogy between two elements, and these two elements may have the same chemical analogy, but can be completely different physiologically speaking. For example, here you've got the calcium, strontium, barium, and radium. They do have good chemically and they are chemically and physiologically similar. But if you take, for example, sodium and potassium, they have strong similarity from a chemical point of view, but they behave completely differently in vivo. One is intracellular, the other is extracellular. And here, the same for the cesium and potassium. They are chemically similar, but they have different kinetics. So before to extrapolate, you should know that. And to know that, you need to get data. And this is a problem. In most of the case, you also have no human data, but you have only animal data. And when in laboratory, we do not work on human. In laboratory, we work on rodents, on mouse, on rats. And all the problem is to extrapolate from one species to another. This is not true only for radiological protection. This is true for in medicine and every field, but this is a real problem. And in the worst case, you do not have real data. You have animal data plus, animal data on chemically similar element. And of course, this is the worst case for us. So you can see that if we sum up, we have many sources of uncertainties. But in any case, what we are doing here, we are doing model to calculate effective dose, and effective dose is there to optimize the exposure. So because of that, and the effective dose is made for the reference man and the reference female, for reference person. So because of that, we say that the reference model and parameter values, they are fixed by convention, and they are not subject to uncertainty because, as I told you, they are intended to be used for optimization and demonstration of compliance with those limits. So again, when you calculate effective dose, the effective dose is by definition not uncertain. Of course, if you want to do something else than calculating effective dose, if you've got other objectives, our models are so sophisticated that you can use for every other application. You can use them for pharmacology, you can use them in science, you can use them for research or whatever. In such a case, you should calculate and you should know the uncertainties and the variability, and this needs to be taken into account. So if I try to conclude, I think I have succeed to convince you that determination of internal dose is definitely a complex procedure, but thanks again to ICRP, we have many tools which are available to directly assess the dose for directly assessment of the activity. This is based on the use of biokinetic and dosimetric model, and at the end, for the effective dose, we have no uncertainty for the calculation of effective dose. And that's it. Thank you.